Okay, welcome everyone to this webinar. I am so excited to welcome you on behalf of the Epidemic Ethics Working Group and Network. Today's webinar is going to be on balancing COVID-19 with other health priorities, something that many of us have been thinking about, many of us have been talking about, but today we get this opportunity to have a wonderful discussion. My name is Adnan Haider. I'm the Senior Associate Dean for Research at the Milken Institute School of Public Health at George Washington University in Washington, D.C. in the United States. I'm also a professor of global health, and I call myself a student of bioethics as well. I am so excited at giving the opportunity to moderate this wonderful webinar, and I'll be introducing you to three amazing panelists today. Before we begin, some housekeeping. Please note that we have a chat function where you can introduce yourselves and welcome yourself and talk about issues, but we also have a Q&A panel, a question and answer panel. And I would like you to use the Q&A panel to post your questions. If you like a question of somebody else, please like it so that we know which are the questions that all of you want me to get to in order to address them with the panelists. We are also recording this session. The recording will be available on the website of Epidemic Ethics. We are also live streaming this session on Facebook. And so there will be many, many opportunities if you have colleagues who could not make it today for them to take advantage of this webinar. I want to thank the organizers for pulling us together and really for introducing this topic where we've seen that in the context of COVID-19, a number of health and health-related issues, in some instances, we feel have gotten less priority over the past 18 months. In fact, in many instances, both at the individual level and at the population level, there have been concerns about the impact of what people are calling the single focus on COVID-19 compared to many other health and disease conditions that afflict human populations around the world. Today, I'm very excited that we will get an opportunity to think a little bit more about that. What do we do to address this balance? How do we set our priorities? What are some of the ethical criteria that we could use in order to negotiate this issue? How do we think about justice across these competing priorities? These are just some of the issues that I hope we will be able to tackle. And I'm excited that I'm here with an amazing set of panelists, not only who represent the diversity and depth of perspectives that we need on this topic, but also who come from different regions. So they bring their regional perspective into this conversation as well. I will introduce each one of them in turn and then request them to present some opening comments, 5 minutes or so, about their reflections on this issue of balancing health priorities with respect to COVID-19. And after that, we will open the discussion. We will come to your questions. Some of you have already submitted questions in advance, and others will do that using the Q&A function. So once again, thank you so much for joining us. And I'm really excited today to start by welcoming Dr. Bridget Pratt. Dr. Pratt is a senior lecturer in ethics, in healthcare ethics at Queensland Bioethics Centre at the Australian Catholic University. Previously, she was an ethics researcher and Senior Research Fellow at the School of Population and Global Health at University of Melbourne. Bridget's interest is not only in research ethics and health systems research ethics, but also largely on the application of justice, equity, and social justice in particular. I've been a fan of Bridget's work for many years, and I'm so excited. Thank you, Bridget, for joining us, and over to you for your opening reflections.
Yeah, thanks, Adnan. And I think a bit of that social justice flavor will color the direction of some of the things I'm going to say. I want to start out by just saying that I am based in Australia, and so we have largely been able to control COVID to some extent, pretty much by shutting our borders and having lockdowns every time we get, like 5 or 10 cases in the community. So that's kind of what our experience of COVID has been over here. And I'm just going to share my screen. And so I think from my perspective, two of the priority health areas that have really gotten displaced or kicked off the agenda by COVID are climate change and equity. And I know at the start of COVID, there was a lot of talk about how it was actually having a positive effect on climate change. You know, people weren't traveling on planes, people were working from home. And I think carbon emissions went down about 6 or 7%. But historically, whenever there's been a big world event like a pandemic, there's been a bounce back effect where these sorts of emission declines rebound. And we're already seeing that happening. There's been a lot of talk, I guess, about countries having green recoveries where they're going to spend their stimulus packages in ways that actually improve the environment, and we're going to have a big reset. But from the data, it actually looks like a lot of countries aren't doing that, and they're spending their stimulus packages in ways that actually are detrimental to the environment. Also, at the same time, because of COVID, there's been an impact on what kind of climate science data we can collect. And people haven't been able to collect certain data about the climate that they used to be able to. And that's going to actually impact models that predict things about the Arctic regions and also the oceans going forward. So I think most recent estimates have suggested that we've maybe shaved off, I think, 0.01 degrees Celsius of where we're heading by 2030. So essentially, we're still on track to increase world temperatures by 3% by 2100, which is going to be catastrophic for both human and ecological health. So I think climate change is still a really important task, and it's certainly not one the Australian government is particularly interested in, but we'll see where that goes. And then secondly, I think equity. I think COVID has exposed and exacerbated a lot of health inequities and the structural determinants of health and inequity. Just in terms of it highlighting how racism, colonialism, ableism, sexism, how all of those and other factors increase people's risk of ill health. I think that's a massive lesson that COVID has reinforced. And in terms of COVID and equity, I mean, you've seen an unequal risk of disease burden in a lot of countries based on race, ethnicity, and being from socially marginalized groups. In Australia, for example, the aged care sector has been hit hard, largely because it relies on a casual workforce that are from socially marginalized groups who work across lots of different aged care facilities and can't take time off when they get sick and don't want to go and take a COVID test because they might not get paid. You've also seen an unequal impact of public health measures on people. So, for example, lockdowns, which we keep having every 5 minutes in Australia, it means anybody who's a casual worker is suddenly unemployed, and the federal government steps in, well after the fact, and a lot of people probably go without pay for quite a substantial amount of time. And then we've had an increase in domestic violence here in Australia because people are stuck in their homes. And I mean, technically you can leave if somebody is going to harm you, but the lockdown rules make it a lot more likely that you're going to be in your house with abusers than you otherwise would have. And then there's also an unequal impact of all these stimulus recovery measures, and they don't necessarily help everybody who's been negatively impacted by lockdowns as much as others. So there's an unequal impact of those stimulus packages and who they help and who they leave behind. So in light of all of that, I think it's really important that equity get back on the agenda, and that really means addressing the roots of social and health inequities, which are power relations. And decolonizing the way global health is performed is also going to be a key element of addressing the root causes of health inequities, I think. And I also want to flag that while I've said equity and the environment are two priority areas, there are tensions between trying to improve both of them. There's a lot of growing evidence that shows, for example, that cities, when they're implementing climate change plans, they actually are exacerbating inequities or even creating them. So for example, there's a lot of work being done to green cities, which means, increasing the amount of trees in the city, increasing parks, increasing green cover through cities. And that often has the effect of gentrifying areas and displacing lower income residents, and making areas richer and more affluent. And in terms of cities, when they try and decrease flooding, they often do risk assessments where they say that poor and marginalized areas are at risk of flooding, and those people need to move, and they get displaced. Whereas other rich, more affluent areas that are actually in flood zones are not at risk, and so they actually implement displacement of marginalized groups and not of rich areas. So there's a lot of tension between pursuing those two research and health priorities at the same time, which I think is important to recognize. And lastly, just going to the other question that we were asked, which has to do with how do you balance COVID versus other health priorities? I think there's been a bit of work done by Carly Krubner and others to develop an ethical decision-making tool around these issues. And I think it's a good starting place. The first step in their tool is to identify what health services have been disrupted by COVID. So which ones are not being resourced anymore because of COVID, or to a lesser extent, or which health services are people not able to access due to lockdowns or other COVID-related issues. I also think, in addition, it's important to think about what health conditions COVID has actually increased demand for. So, for example, mental health services might be one area where COVID has actually increased demand. So it's important to think about what health conditions have an increased demand. And then also other priorities that I mentioned around climate change and equity. And then the next step is then to assess the urgency and severity of not addressing those issues in order to prioritize. And I also think assessing the impact of not addressing them on marginalized groups and equity is also important to assess when prioritizing. So I'm going to leave it there and hand back over to Adnan.
Thank you very much, Bridget. That was a very comprehensive 5 minutes indeed. And I very much appreciated your balancing and emphasis on the environment, which we will come back to, and concerns on competing needs, and also your closing and considerations for how to balance competing health needs. Thank you so much. And we will definitely pick up on those points. I now am very honored to welcome the next panelist, Professor Deborah Diniz. Professor Deborah Diniz is an anthropologist and professor at the University of Brasilia in Brazil. She's also the co-founder and researcher at the ANIS Institute for Bioethics. Professor Diniz has worked on gender, health rights, feminism, and ethics for a long time. In fact, she's been honored with the Dan David Prize in International Leadership in the field of reproductive justice and gender equity. She has been working on the impact of COVID-19, particularly on women, and the role of vaccines. And today I'm very excited to ask Professor Diniz to comment and provide early reflections on the topic of how do we balance COVID-19 with other health priorities. So over to you, Professor Diniz.
Thank you. Thank you. Do you hear me, right? Okay. So it's really a pleasure to be here today with you, and thank you for having me. I need to say that I'm speaking from the most impacted region in the globe, that is Latin America and the Caribbean at this moment. As a Brazilian, my voice is one among several who struggles with how the pandemic intersects with our previous inequalities, mainly gender and racial inequality. And also I want to highlight, because I will, link to what we published yesterday at the Lancet. I'm a member of the United Nations University, the International Institute for Global Health, Gender and Health Hub. And yesterday the group published a piece at the Lancet after the commitment of several governments to invest on gender equality. And you see the 4 commitments of the UN system, and one of them is to tackle the structural determinants of gender inequality on vaccine deployment. So there are certainly many health priorities to be discussed here, but all my answers will be viewed from the perspective of women, girls, and gender diverse people who can become pregnant. My point in response to this question is very simple. All emergency preparedness and response must center sexual and reproductive health, and it must do so by taking into account how bodies of people can become pregnant, will not only be affected by the disease itself or other emergency in question, but also by considering how their sexual and reproductive health needs will be met. It's so basically, and it should be so, simple to be taken in consideration. But what we have been seeing in COVID, it's not. It's exactly the opposite. No health emergency puts basic SRH needs, contraception, pregnancy, maternal health, abortion care in pause. So an emergency after emergency, we continue to normalize the defunding and interruption in services during crisis, which tends to be intensified under conservative or authoritarian governments. And it's the case of the majority of Latin America and the Caribbean today. So there are some of the obvious results of not centering sexual and reproductive health during emergencies. Increases in gender-based violence, unwanted pregnancies, unsafe abortions, maternal mortality and morbidity, and a disproportionate impact on racialized women and girls, migrants and refugees, gender diverse people, sex workers, and it can expand the list. But what we are seeing in the context of COVID, our health systems are unprepared to care for women and other pregnant bodies, regardless if they have COVID or not. For over a year now, we have been gathering evidence of alarming pregnancy and postpartum mortality risks posed by COVID, and further aggravated by the disruption of the services. And pregnant people continue to be neglected and excluded from both COVID vaccine research and high priority groups for COVID vaccination. So science uncertainties are always used against women, and we cannot understand vaccine inequity without taking gender into consideration. In Brazil, where the vaccine is already poorly available, pregnant and postpartum women are taken to the courts at both local and national levels to fight for priority access in vaccination. So as a result, COVID is quickly becoming one of, and if not the single one, leading causes of maternal mortalities in countries like Haiti, the only country in the Western Hemisphere where vaccination has yet to start. In Brazil, where just 1 in 5 people are fully vaccinated. In Mexico, where 1 in 5 people of the total population are vaccinated. And in India, that is poorly 6% of the population. And again, when we look to the intersection with other from previous inequalities, the situation is even worse to women. So to conclude, when we do not put sexual and reproductive health at the center of emergency responses, women's needs and interests are not considered nor cared for, regardless of how much they are directly affected by the emergency itself. And holding sexual and reproductive health as a priority during an emergency like the COVID pandemic is not just about protecting women, if you prefer, if you consider that it's, too feminist here to speak about women, girls, and pregnant people. So let's consider that it's about protecting future generations. And this is exactly what we mean by reproductive justice issue. Thank you.
Thank you very much, Deborah. That was a very, very important reminder to all of us, both because you have profiled in some ways the importance of a vulnerable population and highly neglected areas, which even without COVID, even before COVID, were being neglected and were suboptimal, and now have been further shaken up as a result of COVID. And so thank you very much for those important issues around sexual reproductive health, pregnant women, young women, etc. We're going to come back to some of those points, I hope. Very much appreciate your perspective, especially from Brazil. I'm now excited to introduce our next and final panelist, Professor Cesar Atuere. Professor Atuere is a lecturer in the Department of Philosophy and Classics at the University of Ghana in Ghana. His areas of research are, of course, sociological, anthropological research and their implications, particularly in issues of multiculturalism and technological innovation, focused particularly in Africa. Currently, he's a visiting professor at St. Gallen University as well as in Switzerland. He's a member of the WHO ACT Accelerator Ethics and Governing Working Group, so he's immersed in these issues around COVID. And I'm particularly excited that he has joined us today to give us a perspective not only from his own ideas, but also from Africa. Over to you, Professor Atuere, for opening reflections.
Thank you very much, Adnan, and thank you all for inviting me and all those who have joined us online also. Thanks for making the time to join us. I'm speaking to you from Ghana on the west coast of Africa. Just for your information, the vaccination rates in Ghana today are less than 2.5% of the population. That's the level of, inequity and inequality in the distribution of vaccination rates across the world. But I'm going to focus on the topic of today's webinar. It says balancing COVID-19 with other health priorities. When I looked at this topic, the first thought that came to mind is that, well, the horses have already bolted from the stable. In other circumstances, I've actually said we are living through an over-COVIDization of healthcare, which means that most energies are directed towards COVID. And naturally, especially in countries with limited resources, if you have limited resources and you push a lot of these resources onto one particular disease, other diseases suffer. So from an African viewpoint, one of the things that was happening on the continent prior to the outbreak of the pandemic was a greater focus on non-communicable diseases, because the healthcare systems on the continent had been designed to tackle communicable diseases, cholera, malaria, but we're seeing an increase in non-communicable diseases and lifestyle diseases. Now, the focus on these diseases requires attention, human resources, and dedication over a long period of time. COVID has disrupted this particular development that was going on. And therefore, we have situations of, people actually in some parts, for example, in Ghana, my research shows, and this is actually ironic, that attendance to hospitals diminished during the peak of the pandemic because people were scared to go to the hospitals for fear of being tested positive and eventually being put away in an isolation center. Now, this does not mean that people were not falling ill, but it's perhaps because they were withdrawing from the normal healthcare system, which means that there is a lot that we are yet to discover in terms of actually calculating the damage that was done. And other programs for combating diabetes, obesity, hypertension that were going on, most of these had to be interrupted because a lot of the resources were being directed, human and material, towards COVID-19. Now, in the face of all this, if the horses have bolted and we're trying to close the door, I'm going to try and sound, let's say, a more optimistic note. Both Bridget and Deborah have highlighted some of the challenges, and they are real challenges that are emerging from this pandemic. But the question then is, what do we do? And my view is this: we need to do embedded research with an eye on plowback for other diseases. And this is the position that I'm going to try to defend. Embedded research, which means that we need to keep doing research as we're going along, because the pandemic is evolving, we're learning new things. And while we're learning these new things, we should not focus only on COVID, but see how we can plow back the gains that we are making to help us with other health threats that exist in our communities. Because it is already late, we're all investing in COVID. And incidentally, from a low and middle income country and an African viewpoint, one of the interesting things that we actually find is that the focus and attention on COVID is also linked to the type of people who were first infected by COVID. COVID started off in the high-income countries, and it entered the low and middle-income countries through our international airports, which means among the upper and middle classes. And initially, actually, when the lockdown measures and the response measures were designed, they were designed and tailored to meet the needs of people who belong to the middle and upper classes, because they are the people who have water at home, who have fridges at home, who have electricity, who have money to buy food. Like Bridget said, people in vulnerable communities actually shared a disproportionate level of burden from these public health measures. But looking directly at the thesis I'm trying to propose, that is embedded research with an eye on plowback for other diseases, we need to keep in mind something. The reaction to COVID was a sort of knee-jerk reaction. And what most countries did was to create organizations, specific organizations, task forces, for example, advisory groups to tackle COVID. The advantage of these ad hoc organizations that was created was that they are nimble, active, and can actually solve problems immediately. However, a number of these organizations were working or are still working without being sufficiently embedded in the existing structures. And a lot of money is going to these organizations. So we're talking about setting up, in high-income countries, building new hospitals, also in low and middle-income countries, building new structures, creating new laboratories for testing, doing all sorts of things. Now, the fact is, how are all these investments going to be plowed back in such a way that they can actually serve the population and serve the general health? Because at the end of the day, when we're talking health and even returning to the topic, when we say balancing COVID with other health priorities, the person who is sick is one person and the health is one. You don't have COVID health and other healths. So whatever we do for COVID should also assist the general health of the population. And now, so these emergency structures, we need to do embedded research in them and make sure that there is plowback. And this also needs to happen, and the debate is actually going on. You mentioned that I'm part of the Act A ethics working group at the WHO. Even the Act A that was created at an international level is now asking questions about what happens as the pandemic dies down. And there are ideas that are being thrown out of creating a global health treaty for emergencies and all that. These are reflections that we need to carry out and do them well. Otherwise, we will fall back on what Albert Camus says in his book, The Plague. Everybody knows that pestilences have a way of recurring in the world, yet somehow we find it hard to believe in ones that crash down on us, on our heads from a blue sky. There have always been as many plagues as wars in history, yet always plagues and wars take people equally by surprise. And we need to avoid that situation. And this was written back in the 1940s, yet it still keeps happening. So there is good news in the midst of all the tragedy. We have learned a great deal as a result of the pandemic. I mean, if you just think of the public, how many people actually knew what droplets were and how far a droplet travels? In terms of public health, at least in our part of the world, we have gained a lot. Public health had been neglected for a long period. We've gained a lot. Fumigation of markets, deratization, cleaning of gutters. People are now learning how to wash their hands more. How can we ensure that these good health practices have a fallout and actually last and are sustainable over time? Diagnostics. At the beginning of the pandemic, a country like Ghana had only 2 centers that could test. Now we've suddenly reached a position where all the regions, 16 regions, can test for COVID. If we have built laboratories, what is going to happen with these laboratories and all this investment, which is from the public purse, after we no longer need to test for COVID? How do we integrate all this learning? And if we talk about vaccines, just to be quick, even the fact that vaccines were developed in such a short period of time, that is learning for humanity. How can this be plowed back? And the whole idea of talking about, waivers, IP waivers, and the opposition is usually that, well, it's too late, it's not going to serve for this pandemic. But the question of actually making countries become more sovereign in governing their health systems is a move against the decolonization of healthcare. And this is important for future sustainability. And of course, equity and governance, it's looking at us in the face. What are we going to do about it? So I think the horses have bolted. There is no balance between the concentration of COVID and other diseases. But in the midst of all this, we should not go for a kind of reactionary approach to say, well, let's go back to the way things were. Let's think more, and if you permit me to use Marxist terminology, of a spiral growth. We're going to go back, but we have to go back and meet at a higher point. And that is my view on this. Thank you.
Thank you very much, Cesar. Very, very important and critical reflections, both in terms of the analysis of the problem, but also I love your positivity and your optimism of education, growth, and learning. So thank you. And we will definitely come back to some of these points. So ladies and gentlemen, we've had a wonderful round of opening reflections from our 3 panelists. And I have seen a number of questions that were sent earlier also in the Q&A. If you have additional questions, please post them in the Q&A. We will try our level best to address as many as possible. And if I could request our technical assistants to put us more in a communal zone, then we'll be able to look at this. So let me actually go back to Bridget. I think all of us cannot ignore a number of questions are relating to this whole, obviously, implication of equity, particularly vaccine equity right now. It's at the top of a number of people's. And while I think that it may not be exactly in terms of our ability to discuss competing health priorities, I do think it's a very, very critical issue. And a number of our participants want reflection on that. So Bridget, from your perspective, as you look at this, how do we address this issue? The fairness and equity considerations are very, very clear. Give us a few reflections on that.
I'm sort of going back to what Cesar was just saying about kind of the horse bolting. There was so much talk at the start about a people's vaccine and how it was going to be cheap and it was going to be distributed to everybody. And it's also interesting that you said in Ghana that the full vaccination rate is 2%, because in Australia, it's about 10%. So we're not doing a lot better. And that's partly because we bet on AstraZeneca, not because we weren't hoarding vaccine. Yeah, it's been tricky because I've watched the US from kind of a distance, and I'm originally from there. And it felt like they've hoarded the vaccine, and the fact that England's been able to vaccinate nearly their entire population. I mean, it's definitely not consistent with principles of social justice. It's not how I think a lot of the ethical resource allocation formulas that take into consideration justice and fairness have suggested the vaccine be allocated. I mean, I think they were calling for more priority groups in every country to be vaccinated first. And yeah, politics has definitely gotten in the way of ethics, I think, on that one. I don't know what the answer is. I mean, Australia can't even figure out how to roll it out here. And we're definitely not giving it to, I think, oh yes, we are giving AstraZeneca because they no longer want to give it to the population here. So, I mean, we're not doing a responsible job of helping countries in the Asia Pacific, which is where Australia's foreign aid has usually gone when they've given it out.
No, thanks, Bridget. And Deborah, in some ways, it's a really challenging question. That's why I've started with it, so that we can just, ease into some of the other critical in-depth issues. But from your perspective, sitting in Brazil and facing the pandemic, as you all have, some countries are thinking about a third dose for their populations, as some of our panelists, some of our attendees are reminding us. How does that work, especially for vulnerable populations like pregnant women, for example, where certainly the current recommendation is that COVID is far worse for pregnant women than the vaccine. Therefore, certainly there's recommendations in the US for vaccination. Your thoughts on that, Deborah?
Thank you. I think that the question is about how we handle and how do we survive to permanent and insidious inequalities. So the booster is just about that. And I would reframe the question saying, how do we understand vaccine inequity in our lives? Vaccine inequity is not just about individual rights or individual needs or country needs and way of protections. It's about all of us. If we do not understand that the subject of a vaccine discussion is us, and it's not my family, my country, that is about us, it's about global health, we'll have a third wave, fourth wave, a new variant. So we need to reframe the question about, I will have this third, vaccine and the others will not have the first one, will not solve the problem. So is our way of thinking about who can afford something in health and how do we protect all of us and the new generations? I think that we need to reframe the way that we think about global health.
Very well said, Deborah. And I'll come to this issue of reframing in a few minutes as well, because I think that the dialogue that we are having in many instances is about division and seeing us versus them as opposed to solidarity, which is important from a justice perspective as well. But Cesar, I think just to end this cycle of conversation, I want you to come in on the fact that this is not the first time we've faced a epidemic of this proportion or a pandemic. I mean, ZIKA was there. So how does your optimism weigh? Have we truly learned from the previous? You're talking about the learnings from this one, and you hope for it to be sustained. But there are critique of that to say, well, really, did we learn from ZIKA? Did we learn from the previous epidemics? Over to you for a thought on that.
Well, I suppose one of the great lessons of history that we learn is the fact that we don't learn from history, but that's fine. That's cool. No problem. That's how we are as humans. However, let me point out something to stick on this, to stick to the optimistic approach. Take the HIV AIDS pandemic or epidemic in the 1990s. And the question of retrovirals. It took many years to convince the world to make these key health resources available to the poorer people. At least with COVID-19, it hasn't taken us that long. It hasn't been successful, but right from the very beginning, the debate started. So something is being done. We haven't achieved the result, but at least we've moved, I think we've edged a little bit forward compared to past cases. We should not be complacent with what we have achieved because it's actually dismal, but at least we've made a step forward. Now we're beginning to talk solidarity, and I mean, I just published a paper on solidarity with regard to vaccines on this. Just to make it simple, the fact is this: once we start thinking of the whole world, global health, we are a team. And like any team sport, if I may use a sport, kind of sporting image, I mean, you can be a great goal scorer, but if your team loses, you have lost. And whoever is thinking of just fighting for their own little angle, country, or region is like somebody who's not playing with the team. And the concept of solidarity, which I think we really need to work on, and some of us are trying to do this, is that solidarity is not the practice of good guys. Solidarity is the practice of decent human beings. Therefore, it is normative. And it is not for countries to say, well, I've finished vaccinating all my population and then I will hand over the excess doses. That's just being a nice guy. What we're calling for is to be a decent person. Thanks.
Thank you, Cesar. And I think you've raised a critical point. I will come back to you because I am speaking to you from a country where solidarity, global solidarity, is a bad word sometimes, and where feelings of nationalism are being evoked in order for political gains and other purposes. So Deborah, I mentioned ZIKA, but I know that has huge implications for the population that you deal with. Talk to us a little bit about that.
Yeah, I want to follow Professor Cesar saying that in a period of 5 years, Brazil was at the epicenter of ZIKA and COVID, and the same population was affected. So women at reproductive age, and we still have ZIKA, and nobody's speaking about that. And the aftermath of this first epidemic is now forgotten. And what the lessons could we have learned, if I can, make this question to the future, that the social determinants of health, they are determinant to know who will be the most impacted. We also know that the response is not just about health, it's about social policies. We need social protection. We need, in COVID, that people have the conditions to social distancing, because we're now discussing about vaccine. But connected to vaccine is the way that our societies found a way to organize that people can be at home. So when you have a deep inequality, I mean income inequality, the most fragile part of the population has no possibility of doing what we're doing now. So the sign, the face of our social privilege is here. And we learned that in ZIKA, that people need social protection, so they need income. And finally, we need to speak the truth. So I do not accept any postmodernist idea of truth. We have the truth, and the truth is about social distance, it's about vaccine, it's not about fake science.
Well said, Deborah. And I think that the national and global health systems' responsiveness to previous learnings in correcting those social determinants of health leaves a lot to be desired, because we have repeated these types of discussions. So Bridget, let me bring you in by saying, so what role can an ethics lens play to support us in these discussions, right? We're looking at all of this complexity. You talked about a particular framework that some of your colleagues have worked on. Talk to us a little bit more. Can you expound a little bit more on how ethics can give a better lens, particularly in view of the positive optimistic perspective?
I think that ethics is really good at teasing out different values and considerations at play and helping you figure out which avenues advance which values. So certain avenues would advance values like solidarity, and others would advance other values like nationalism, or perhaps people might make an argument for utility, or other avenues might advance equity. So I think ethics is a good lens for teasing out which values are at stake and which values people care more about in the long run. And I think at the moment, it seems like at least country governments care more about their own citizens than the global community. And so they may be looking at it from kind of a maximizing the benefit, but only within their own national community. Whereas Cesar was talking more about solidarity at the global level, and building that sort of normative framework or that normative position globally is something that's been written about in the justice literature and philosophy as being very important, but how one builds that norm across the globe is something that hasn't really happened at this point. And it's something that's important, but I'm not sure how or that is going to be happening, but it's a priority given that it seems essential for having an appropriate response to COVID.
Yeah, no, I think all of us probably in the audience believe in some of that lens. So Cesar, could I come to you because I think that there is indeed a call for this in terms of global solidarity, but a couple of the participants are raising this issue. What if we had better preparedness embedded in public health systems? Then we wouldn't be all the time diverting resources from one issue to another issue to respond to these emerging threats or to these epidemics or acute crises. And if we reached equilibrium where everybody can address such things, we would be in a better state. So talk to us a little bit about, do you think that thought experiment could work?
Well, yes. Anyway, to start off with on solidarity and what Bridget just said, and I think it's also linked to what Deborah said. It's true, most of the conceptions of solidarity that we find in political philosophy and even in bioethics tend to be a little bit, to use the words of Dawson and Virgil, a bit opaque. So we cannot, as it were, tease them out into concrete normative frameworks. However, I think that the time has come really for bioethics, just picking up a little bit from the previous question, to move away from that conception, which is all about the individual and the individual's entitlements, to start thinking more in a broader framework, which is an us framework. And that us framework, we can actually use solidarity. And one of the things that I know some people are working on is, can we build a kind of solidarity scoreboard or a solidarity index to rank people who act in the global health field and let them see whether what they're doing is actually responsible to the global community or not. And I think it will be interesting, even if we start from ourselves as some researchers, perhaps we'll find out that we need to adjust our positions. And then the second point you mentioned, I think something that has emerged, at least from Africa, that is very interesting is the Africa CDC. This was created as a result of the Ebola outbreaks in 2017. And this organization has suddenly become pivotal for the continent in the fight against the pandemic, capacity building, pool buying, negotiations, speaking. And so here we have a sort of principle, if I may invoke another principle, not only of solidarity, but of subsidiarity, which is you allow the smaller organizations to be able to do what they're capable of doing and ensure that they have the power and the and the capacity to do it, because they are the closest to the people. I mean, Deborah spoke about, the communities, the marginalized communities in our cities, in the poor, in the developing world, in the low and middle income countries. Now, quite a number of the policies that are usually taken are taken so far away from these people that we sometimes do not even understand. Empowering communities to be able to act where they are capable is the principle of subsidiarity, and that way we can build more robust health systems.
No, thank you, Cesar. That's a great argument towards developing both capacity, indigenous and intrinsic capacity, but also, if I may use the expression, adaptive capacity from a health systems viewpoint, where systems will respond. Deborah, could I, in view of the time that we are going to begin to, wind up our webinar, I want to go to a very practical level. As a result of COVID-19, health screenings were postponed, preventive workup was postponed. In the communities that you work in, Deborah, think about breast cancer screening, think about cervical cancer screenings, think about, these are real implications for the health of individuals and communities. How can we avoid that in the future, Deborah? What do we need to do? Because you can imagine now the burden of all of those conditions, and my colleagues in TB and malaria are very concerned about the spread of diseases that we've been fighting, particularly on the continent, for centuries. So Deborah, a few reflections on that, and then I'll begin to wind up as well.
Yeah, I would say that I would have Venezuela as an example to respond to you, right? So in Venezuela, the organization that I work with, it's the only one operating in country during COVID for all the issues except COVID. And how do they manage it? They build trust with the community. They find a way to survive to the government, right? They have been surviving to humanitarian situation for a long time. So a humanitarian response or an emergency response, it's not something that you build and you end after the crisis. It's an ongoing preparedness at the community level, because we sometimes we put this discussion at an abstract level of developing policies to respond to an emergency. It's the other way around, that we need to think about how to respond to an emergency. It's from the community level to be there. It's about resilience. It's about creative resilience, and communities they do have. And the concrete example for me is Venezuela. You have a scarcity. You have a lot of barriers. The government is not speaking the truth about the pandemic. And you have an organization that is there before the pandemic to respond to the emergency from a different perspective.
No, thank you. And that's a great example of a real world example that exists and that survives. And I think you've used a word that is fundamental to those efforts, which is the development of trust. Because right now, and we unfortunately were not able to cover that, there is not only this issue of nationalism, that is one country versus another, but within a country, there are issues, and issues about trust between people and governments, and between one types of people to another types of people, as we see in my own country, sitting from the United States, versus your country, versus many of the others. So, ladies and gentlemen, we've got just a remaining couple of minutes, and what I want to do is to give each one of our panelists a final less than a minute reflection on this topic, so that if there was anything that they really wanted to talk about, which we haven't had the opportunity to do so. Let me start with you, Bridget. A minute on any final reflections on the topic of COVID-19 and other health priorities.
I think I'm just going to make a quick plug again for climate change as a massive priority that's neglected, and that will have huge ramifications for people's health. So I think that's really where a lot of effort needs to focus, and not baby steps. We've lost time for baby steps.
Thank you very much, Bridget, and I apologize that we couldn't come to that particular topic, but just to again emphasize that the whole notion of climate health, planetary health, and especially as billionaires are getting fascination of going into space, it seems repeatedly, and the amount they spend doing that versus the opportunity cost of that money. I'm sure we can all have thoughts on that. Over to you, Deborah, for a minute of reflection on any point you prefer.
Yeah, we cannot speak about a new normal, right? All of us know that. So the new possible needs to be intersectional in our thinking. It's about climate justice, it's about gender equality, it's about anti-racism, and we need to make it complex. So we need to avoid our abstractions of speaking about humanity as a block, and we need to dive in about the singularities that put all of us in more risk than others.
Thank you very much, Deborah. And it is vitally important for all of us to be constantly reminded about those issues that you speak about, because sometimes we forget, sometimes we are overburdened, and we may neglect. So thank you. Cesar, final reflections from you.
Yeah, I think, I'll just basically repeat what has been said in the different words. We live in a world in which the two main threats that we have, our health and the climate, are so interconnected. And they're interconnected not just because we are related, but because we depend on each other. And therefore, the solutions that we need to look for are not just a descriptive solution of our interconnectedness, but using the lens of intersectionality, we need to create a new normative language for being interconnected. And this is the challenge of ethics, and I think global health ethics there. We need to learn how to start thinking ethically from a viewpoint of people who cannot do without each other and who need each other.
Well said, Cesar. I think that that's exactly one of our goals. So ladies and gentlemen, first of all, thank you again for joining us. I think our three panelists are not only superb individuals, but they care. They care about the topics at heart. They've done a tremendous amount of thinking, and I look forward to further discussions in various fora. The discussion doesn't end here. The discussion has just begun. We have our papers and our social media to continue these discussions. I do want to emphasize that ethics affords us the opportunity to build on my three colleagues, to ask the question about who's winning and who's losing. And that paradigm where you have winners and losers is a very dangerous one, because it can be used for the positive, but it can also be used for the negative, as we are seeing in many, many countries. So issues of beneficence, issues of justice, issues of autonomy are vitally important. And all of those words, and I'm using them specifically, come from ethics, come from that field, and allow us to really grow. Thank you, Epidemic Ethics Network, for allowing us to have this conversation today. It's been a wonderful experience. I've learned enormously from my colleagues. I hope it's been a great one for you as well. Please stay tuned for the recordings, which will be posted. Please join our Epidemic Ethics for the next webinar as well. Thank you very much for all the work that you do. And here's peace to you all. A prayer of health, safety, and happiness to everyone around the world. Take care now. Bye-bye. Thank you.